Hello and welcome to our lesson about monoclonal antibodies and cytokines. Today we're going to talk about what cytokines are, how they are named, and how they're used in a clinical setting. We're also going to talk about what monoclonal antibodies are and how they're named and how they're used in a clinical setting. So let's start off with cytokines. Cytokines just means cyto, which is for cells, and kines, which is for movement. So you can imagine cytokines is used very often to stimulate cell movement. And the most common use for them is going to be inside of the immune system. They're divided into different classes: interleukins, interferons, colony-stimulating factors. So now these interleukins just means between white blood cells. So you can imagine that interleukins are going to be mostly white blood cell or immune mediated communication. So we're going to talk a little bit about IL-2 and IL-11. Then we're going to talk about interferons. Interferons are going to be released by cells to interfere. They interfere with intracellular organisms, including microbials, viruses, and tumor spread. So we've got interferon alpha, beta, and gamma. Finally, we're going to talk about colony stimulating factors. And these are they do exactly what they sound like they're doing. They stimulate colonies to proliferate inside of your bone marrow. They often have, the most common one is going to be erythropoietin, but there's also filgrastim, sargramostim, rhomboplostim, and L-trombopag. Now, oftentimes they're going to ask you how do we make these kinds of proteins, and that just requires a little bit of fundamental knowledge. If you remember, we often do something like splicing the lac gene, and pretty much what we're going to do is we're going to use endonucleases to put these sticky ends, and these sticky ends then just kind of attach into right here. And so now every time you try to stimulate the LAC-Z gene, which is for lactulase, instead it stimulates the production of these cytokines, and we can collect them and use them in medicine. This is just called recombinant DNA. Let's start talking about interleukins. Interleukins, you only need to know two of them. The first one is going to be aldoleukin, and the way I learn it is because aldoleukin sounds like a German trying to say IL, dose, or 2, leukin, which is interleukin. So just think of IL-2. If you go back to the immunosuppressants, you're going to know that IL-2 is very important for T cell proliferation. So it's very important for T cell proliferation. When would we want T cell proliferation? That's going to be for certain types of cancer that is just very resistant to chemotherapy. Just chemotherapy does not work very well on it. So we kind of have to depend on the immune system to kind of help us out. And that's going to be renal cell carcinoma and metastatic melanoma. Just knowing the mechanism is more important than actually knowing the uses. But that is the two more common uses in there. We're going to move on to oprelevkin. So oprelevkin, if you look at that, it sounds like 11. It sounds like a German's trying to say 11. And that's just the way I learned it is oprelevkin is just 11 leukin or interleukin. So if you just remember that IL-11 is important for megakaryocyte proliferation, i.e. they make more platelets or thrombocytes. So this, of course, is going to be used in cases of thrombocytopenia. Your body doesn't have any platelets. And that can be often a side effect of certain drugs, especially chemotherapy. So let's see some very popular interleukins. We use the mnemonic hot T-bone steak, just to remember what they're used for. IL-1 through IL-6, just use this mnemonic over here. Hot being number 1, T is for number 2 being T, so that'll be T lymphocytes. IL-3 is going to be for bone marrow stimulation, for bone. And then steak EAK is going to be for IgE, IgA, and acute phase protein for IL-4, IL-5, and IL-6 respectively. Interferons are a little bit different because they can be produced by more than just your immune system, and they're often used just to let your body know that this cell is malignant or this cell is infected with something. This cell isn't right, and it just kind of lets the immune system come in and take care of it. So the first one that we need to know about is INF-alpha or interferon alpha. This one is very, very often used for the hepatitis inflammation, especially hepatitis C. So if you want to think of viral inflammation or even malignant carcinoma, just like what we talked about, the ones that are very resistant to chemotherapy like melanoma, renal cell carcinoma, and in this case hairy cell leukemia, they can often be responsive to interferon alpha. And this just increases apoptosis, and it lets your immune system know. The natural killer cells will then know that this cell is infected and they'll kill it. And here's how it works. You've got just like some sort of virus, and the virus goes in, or in this case it could just be a cancer protein that just lets it know that there's something wrong, and that's going to increase the expression of interferon alpha. This is going to do a positive feedback loop, which is then just prevents future viruses to go in. It'll also affect the cells around it to kind of make it more resistant to viruses, but it'll also bring in the natural killer cells, and the natural killer cells are going to come in and they're going to kill the cell before the virus has a chance to spread. Moving on to interferon beta. Interferon beta, I want you to think beta for your brain because it affects a disease known as multiple sclerosis. And multiple sclerosis just means many scars, and that's exactly how you would diagnose it. If you took an MRI of the brain, you're going to see a lot of scar formation right around there. It's just called periventricular scarring of multiple sclerosis. And every time you think of interferon beta, I want you to think of brain for multiple sclerosis. Now, for interferon gamma, I want you to think of gamma for granuloma, and this is just used for getting rid of granulomas. Some people have chronic granulomatous disease. It just means that their monocytes just can't produce interferon gamma. So what they do is they form these granulomas and they don't really activate. They're just kind of like sitting there and they're not really killing whatever infection is inside of the granuloma. So what you could do is you could kind of give this, and it helps people with chronic granulomatous disease. All right, moving on to colony-stimulating factors. Now these are going to be very important for bone marrow recovery. That is bone marrow recovery after chemotherapy or immunosuppressants. If you remember from the immunosuppressant lesson, the number one side effect that they all share in common is going to be pancytopenia. And what pancytopenia means is that you're inhibiting the production of hematopoietic stem cells. And these hematopoietic stem cells means that you pretty much don't get any cells inside of your blood, from erythrocyte all the way to lymphocytes. Now they're pretty straightforward in that if they have something like erythropoietin or EPO, you know that erythro goes directly for erythrocytes or red blood cells. Something of note about erythropoietin is that it's not often just used for chemotherapy or immunosuppressants, but it can also be used for renal failure, and that's because your kidneys are actually the number one producer of EPO inside of your body naturally. Now filgrastim has GRA in its name and stim in its name, so you know it's going to have a granulocyte stimulation effect. And when you want to think of granulocytes, you want to think of the fils right here, and they all have different granulocytes based on like what kind of dye these granules attract. They have different fil in their name, basophil being basic dye and eosinophil being eosin dye. So these granulocytes are going to be stimulated by filgrastim. Moving on to sargramostim, it's got GRA and MO stim in its name. So you know that the GRA stands for granulocyte and the MO stands for monocyte. So it just includes the monocyte lineage over here. Moving on to romiplastim and L-trombopag. So these are often the harder ones for me to pronounce, but they're very, very low yield. I just included them for completion's sake. And just knowing that ROM over here is the same as found over here in thrombocyte, so I think thromiplastim, and it's got stim in its name. L-trombopag is going to be a thrombocyte, it's got like thrombo in its name, and then agonism in its name. So it's just a thrombocyte agonist, and it just increases your platelets or your megakaryocytes that's going to be inside of your bone marrow. I showed you a picture over here of what a dry tap looks like. This is a bone marrow dry tap. This is what your bone marrow would look like if you had severe pancytopenia. Your body's just not producing any cells for your blood. Monoclonal antibodies are probably going to revolutionize medicine. They were first approved in the 1985, and they're pretty straightforward, and they're so versatile. They can be used in cancer treatment, autoimmune diseases, antiviral diseases, or allergies, and just so much more. They're just extremely versatile, but they're also very expensive. I gave you an example over here. Secukinumab is a psoriasis drug, and it's cost about $15,000 a shot. And these patients have to take about 4 shots a year, so that's like $60,000 a year. So they're raising the cost of medicine quite a lot, but they work pretty easily. All you have to do is just identify a target of interest, and then you have to just make monoclonal antibodies, and I'll show you how to make them in just a little bit. You inject those monoclonal antibodies, and pretty much the antibodies will bind onto the target, and then your immune system will do the rest. It'll wipe out that target. And you could just use it for so many diseases as long as you can identify a target. And here's how we would do it. We would stick this target protein inside of a rat, and this rat's plasma cells, or the ones that are making antibodies, are going to start producing. Then we're going to mix these cells with myeloma cells. These are just like cancer cells. And these cancer cells are, after they're fused, we're going to have these hybrid cells. And these hybrid cells are going to then be isolated one at a time, and we're going to harvest the monoclonal antibodies and see which one binds the best towards the target of choice. And then once you've got that, you could just start growing these cancer cells over here, these hybrid plasma cancer cells, and they're going to make a whole bunch of antibodies that you could just collect and use as a drug. Now here's just an example of how they're being named. They often come in as a variable in the beginning of their name, then something that give you a hint about the target, then the source of the monoclonal antibody, whether we used rats or otherwise, and then it's going to be MAB, which is going to be monoclonal antibody at the end. So if you see the word MAB, you know what we're talking about. And here's just some example. If you see the variable part at the beginning, it's just going to be the researcher's choice. Like natalizumab, it's often used for multiple sclerosis. It could have just been named after someone named Natalie, probably a researcher's daughter or something, or maybe the researcher themselves. Then it's going to be followed by a target. Now these targets are often, the constant is going to be very important. Like T is going to be for tumor antigen. The L or the Li is going to be for lymphocyte or immune target. The Ci or Bi is going to be circulatory or blood system. So you're going to think of that. The SO is going to be osteocyte. So is going to be more bone targets. And the VI, of course, is going to be viral targets. Finally, the last part is going to be very important vowel-wise. So if you have an A, you want to think of the vowel for the rat. If you have a U, you want to think of the vowel for human. And if you have an XI, you want to think of a chimeric. It's going to be like a rat-human kind of mixture. And then it's going to end in MAB for the most part. And this MAB just means monoclonal antibody. If it ends in PAB, that just means it's a polyclonal. That means it isn't purely just one antibody. Now here's an example of one. Here's denosumab. Denosumab starts with DEN. That's going to be the variable group, and it just stands for dense. And then OS over here is going to stand for osteocyte. So you know it's going to target something in the bones. And then it's going to be U, which means it's going to be a human antibody. It's going to be human. And then monoclonal antibody. So just that's the class that it's in. So just from looking at the name alone, I know that this is a human monoclonal antibody targeting osteocytes to increase density, just from the name alone. In this class of monoclonal antibodies, they're used to target the immune response. And I know that they're targeting the immune response because they have an LI abbreviation in the middle of them, and that stands for lymphocyte. So whenever I see the LI abbreviation, like adalimumab, I know that it's targeting the immune system. These antibodies will just come up again in the MSK and neuromodule, so it's important for you just to try to learn them now. So the first class that I have are going to be TNF alpha target, and that's going to be really important because TNF alpha is important for very severe chronic inflammation. So we've got adalimumab, we've got infliximab, and we've got certolizumab. Now the first two are more likely to be asked. The last one is not very commonly used, so it's not commonly asked. Just learn adalimumab and infliximab. Learn that they bind onto TNF alpha, and since TNF alpha is needed for chronic inflammatory response, you get no inflammation, fever, or apoptosis that's associated with that immune response. It can be used to treat stuff like inflammatory bowel disease, rheumatoid arthritis, ankylosing spondylitis, and cirrhosis. Moving on, we've got eculizumab. Now, eculizumab, I want you to think of Cu over here as complement. So it's going to target C5, and Li is going to be lymphocyte. So you want to know it's going to target something in the immune system. And that's exactly what it does. It targets C5 complement, and so you don't get the MAC. You don't get the MAC production. And this can be very important for paroxysmal nocturnal hemoglobinuria. And that's just where your immune system starts targeting your red blood cells as if it was a bacteria. And the MAC system just kind of starts attaching to it and causing hemolytic anemia. And the way I memorize it again is E complement lizumab. Finally, the last one is going to be natalizumab. Natalizumab is one of the more popular ones, and it's one of the most likely to get tested about. What you need to know is that it targets an integrin, more specifically alpha-1 integrin. And this alpha-1 integrin is needed for migration. So over here, you're going to have the rolling effect right here, and you're going to have the crawling effect right here, and you're going to have the transmigration effect right here. So what you need, what it actually targets is going to target these integrins right here, right in the middle. So the lymphocytes never really get into the crawling phase, and they can never really commit to transmigration or diapedesis. The use of natalizumab is predominantly in multiple sclerosis. It's used as an injection in a monthly dose, and it decreases the flare-ups of multiple sclerosis. Now here is a class of monoclonal antibodies that are used for targeting cancers. I know they target cancer because they have a TU in their abbreviation, and they can be very heavily tested on in the hem-onc chapter. However, they do tend to be more low yield otherwise. So the first one that we need to know about is alemtuzumab. Alemtuzumab is going to be alem, which is a lymphocyte, and tuzumab for tumor. So it inhibits lymphocytic tumors, and that's just going to be chronic lymphocytic leukemia, which is just a cancer of your leukocytes. And it works by targeting CD51. Rituximab, I just think of Rita is 20 years old, and I know that rituximab targets CD20. And I know CD20 is expressed predominantly on B cells. So that's important for you to know in future classes as well. But CD20 is a marker specific for B cells. So it's going to be specific for targeting cancers or whatnot of the B cell. And that's going to be non-Hodgkin's lymphoma, CLL, or even rheumatoid arthritis. And that's because rheumatoid arthritis is just a lot of B cells making antibodies that cause you to have arthritis. So inhibiting the B cells in general will decrease the arthritis. Moving on to trastuzumab. Trastuzumab, you want to think of HER2 or such news, and that's just going to be, some people call it teat-tuzumab. So teat-tuzumab, just to remember that it's specific for breast cancer, and that's what the HER2 gene is for, the HER2 protein is for. It targets specific for breast cancer. Finally, there's going to be cetuximab. Cetuximab, you've got a tumor over here, so you want to think of it's going to be cancer, and CE is going to be more specific for cephalic. So it's going to be tumors of the head, tumors of the cephalic area. And that's exactly what it does. It inhibits epidermal growth factor. And the most likely cancers that you get on your head is going to be skin cancer because there's a lot of sun exposure on the head. So you want to think of epidermal growth factor right here. Epidermal growth factor receptors, and cetuximab will then inhibit the epidermal growth factor, and it'll prevent cancer from growing. Other antibodies that didn't really quite make it, there's going to be the Digifab. Digifab just targets digoxin. You'll learn about digoxin in cardio. It's used for arrhythmia. It's an antiarrhythmic drug. And this is pretty much a half of an antibody, only the AB portion, not the FC portion of the antibody. And it targets the drug and kind of pulls it out of your system. Another one that you're going to learn about in pulmonary is going to be omalizumab. Omalizumab is, it's going to be MA for mast cells. So MA, I learned that as mast cells, and it targets the IgE. It targets the FC portion of the IgE, and it prevents allergic asthma from occurring. because it doesn't allow IgE to bind to mast cells. Finally, there's also denosumab. Denosumab just works by targeting the rank ligand. If you can remember the rank ligand, what it does is if you have rank ligand over here, it goes into the rank receptor and it activates osteoclast. And this osteoclast will then start eating away at your bones. So what denosumab is going to do is it's going to target the rank ligand and it'll pull it out of the system. So it helps make your bones more dense. That's why it's called denosumab. And then os, it's got os in there, so you want to think of bones. So it's going to be denosumab. And it's binding to the rank ligand to prevent resorption. Now there's going to be abciximab, abciximab, and I think of it as AB because it says A and B, and then 2 times 3 equals 6. So abciximab. So the importance about 2B3A is going to be for platelet activation. You're going to learn about this in cardio module. It's used, some drugs like clopidogrel can target it to prevent platelet activation. And then again, there's a palivizumab. Palivizumab, it's got the VI in there, so I know it's going to target viruses. And PA is going to be paramyxovirus. So it's going to be the paramyxovirus target. And this is just reserved for RSV fusion protein. It prevents the virus from further infecting a kid if they're having a respiratory tract. And it's often used for children because they're the ones that are most likely to have the paramyxoviruses. Finally, the last two that we have is going to be bevacizumab. Cezu is being circulatory system and BI meaning blood vessel. So what you want to think of blood vessel is just going to be targeting the blood vessel growth hormone or vascular endothelial growth factor. And this is just basically prevents the formation of capillaries. It can be used in neurovascular macular degeneration. It's just the blindness that occurs with old age. And it can also be used with cancer because since oftentimes cancer expresses VEGF to increase blood flow to it. So how are you going to use this information? So unfortunately, these drugs are not very heavily tested in medical school, but I think it's just important for you just to take this as just an overview of future drugs to come. They come up in pretty much every module and they have very specific roles. So you want to try to keep them in the back of your head until you need to use them in the future modules.